Good afternoon, everybody. So I'm going to be discussing the role of IMRT in early-stage glottic cancer. I think, as everybody is aware, IMRT is pervasive for almost all head and neck subsites, certainly for locally advanced disease. The only subsite and tumor type where IMRT has not penetrated as pervasively as in early-stage glottic cancer. So I want to make a little bit of an argument for why I think there might be a benefit to IMRT in T1 and T2 N0 glottic cancer. All right, I have no financial disclosures. So by way of background, as everybody is aware, conventional radiotherapy affords excellent local control in node-negative T1 and T2 glottic cancer, with the T1 setting, local control at 5 years being between 90 and 95%, based on the randomized trials referenced here. And in the T2 setting, the RTOG recently reported their own experience with hyperfractionation, showing local control at 5 years between 70 and 80%. Altered fractionation appears to have some benefit in early-stage glottic cancer. Because disease-specific survival is so high in this disease, the concerns about the late effects of radiotherapy become paramount. And the literature is most robust with regards to the risks of cerebrovascular events after radiotherapy. This is just a sort of a sampling of the literature out there. Smith et al. From MD Anderson at the JCO in 2008 looked at locally advanced head and neck cancer patients from SEER analysis and showed an increased risk of cerebrovascular events in patients receiving definitive radiation therapy compared to those receiving surgery or surgery and postoperative radiation therapy. Second publication in JCO, I'm going to butcher that name, so I'm not going to try to pronounce it, but showed an increased risk of stroke in young T1 and T2 N0 glottic cancer patients compared to the general population, with a relative risk increase of 5.1. With the absolute risk increase, obviously not that substantial. 8 strokes were observed versus 1.5 expected. And then most recently, out of the University of Wisconsin, Hong et al. Showed no increased risk of cerebrovascular events, comparing RT in a SEER analysis of T1, T2 elderly glottic cancer patients to surgery. And that's the hazard ratio and the p-value for their multivariate analysis. But I think the data, at least in young patients, is a bit more robust. And so the question becomes, how can we mitigate the risk of a cerebrovascular event induced by radiotherapy as a late effect, while at the same time preserving the excellent local control that we currently enjoy with radiotherapy? As everyone knows, the traditional radiation fields for T1, T2 glottic cancer are simple parallel opposed fields. The question is whether IMRT, by decreasing the carotid dose, might reduce the potential risk of stroke. And you can see here on the left a classic parallel opposed field from a paper out of the University of Florida. And then most recently, out of the UK, there's several papers that show slides very similar to this. You can see the benefit of carotid sparing here in terms of a reduction in mean dose to the carotid arteries. Whoops. Uh-oh. Let's see if I can maneuver this. Uh-oh. Skip button? All right, let me try that. Where's our tech guys? We're sort of limited functionally here. Oh, all right, hold on. All right. What did you say?
Backward, oops. One back and then.
Yeah, I can see it's just got me stuck on the thing.
Excuse me, is there some guy too?
Maybe someone's back by the computer. Maybe if you go to the back and actually move the mouse. Sorry, guys, just a little technical difficulties. Oh, we got another pointer. No, that's not going to work either. Suzanne will save the day here. I'll keep you guys waiting with bated breath for the conclusion of this talk. Just chat amongst yourselves.
Okay.
All right, perfect. There we go. So, the pros and cons of IMRT in early-stage glottic cancer. Clearly, the pro is a potentially reduced dose to the carotid arteries. The con, and the strongest argument against the use of IMRT here, is the risk of marginal miss, and thus compromising the excellent local control that we currently enjoy. So in terms of the pros, there have been several studies that have looked at the dosimetry of IMRT versus parallel opposed fields. Rosenthal et al. Out of MD Anderson reported in the Red Journal a comparison of the parallel opposed fields in IMRT for 6T1 and T2 larynx cancer patients, showing fairly convincingly and not unsurprisingly that mean dose to the carotid arteries, both left and right, is dramatically reduced by the use of IMRT compared to parallel opposed fields. And then from our own institution, we contoured out the CTV and PTV. The CTV was the entire larynx. The PTV, we used either a 5 millimeter or 1 centimeter expansion, were contoured on representative T1 and T2 and 0 patients. The parallel opposed fields were created with the posterior border at either the anterior or mid-vertebral body in the sup-inf dimensions from below the hyoid to the cricoid. The IMRT plans were then created with optimization looking for a PTV D95 that was greater than 95% of the prescription dose. The prescription dose you can see there, fairly standard. And the carotid arteries, and this is an important point in cross-paper comparisons, how you contour the volume of the carotid arteries that you contour out is obviously going to affect your mean dose. And in most of these papers, the mean dose to the carotids is what we're looking at. So we showed here, you can see the two representative plans from our own treatment planning system. So the bottom line here is that IMRT obviously dramatically reduces the dose to the carotid arteries. You can see that in the bottom panel. Now, if you push the posterior border of the parallel opposed field anterior enough, you can get a carotid mean dose that is commensurate with IMRT, but what you will end up doing then is underdosing your outline PTV. So our conclusion was that IMRT both offers the ability for carotid sparing while preserving therapeutic dose to the PTV larynx. So the dosimetric studies have demonstrated the feasibility of carotid sparing without target coverage compromise. Although, to be fair, the dose limitations that we're looking for the carotid artery are unclear. There's some breast cancer data that suggests that every 1 gray increase in mean dose results in a substantial increase, a statistically significant, whether it's clinically substantial is unclear, but a statistically significant increase in the risk of cerebrovascular accidents. So we've chosen to use a mean carotid dose. But the question remains, do the tighter margins, I mean, these are all just planning papers. The question remains is, do the tighter margins associated with IMRT increase the risk of the target moving out of the path of the modulated beams and then thus increase the risk of local failure? So inter- and intrafraction motion of the larynx is largely due to neck flexion differences between each treatment and differences, intrafraction differences because of swallowing and breathing. And these movements in target motion are most dramatic in the sup-inf dimension. And I think when we think about how we're going to adjust the margins to spare the carotids, that adjustment is in the anteromedial direction, not the sup-inf. So from a first principle standpoint, we wouldn't expect carotid sparing IMRT to result in marginal misses. But what do the data show? This is from our own experience in reviewing head and neck of parallel opposed fields versus IMRT in T1 and T2 N0 larynx, 282 patients with parallel opposed fields, 48 IMRT treated, 43-month median follow-up. You can see the borders here, which are fairly standard. The carotid constraint that we used, which was partially pulled from thin air, quite honestly, was 52 gray mean dose. You can see here the Kaplan-Meier graph of local control showing no substantial difference. The local control at 3 years was 88% versus 89%. And then you can see here the vast majority of the local regional failures involved the ipsilateral true chord. There was no difference in isolated regional nodal failures. The reason I mention that is that one of the criticisms initially of using IMRT in early stage glottic cancer was that with the parallel opposed fields, at least you're covering a substantial portion of the grade or the level 3 nodal basins. With IMRT, as you might have noticed from the plans that were displayed there, we aren't covering any nodal basins. So there was some concern that maybe the parallel opposed fields would be sterilizing, even though the risk of nodal disease is low, would be sterilizing the nodal disease. And that that IMRT plans would not result in that, and we'd have an increase in isolated regional nodal failures. And we certainly didn't see that in our data. What we did see, and this is obviously on patients treated, not some dosimetry study, we did see a reduction in mean carotid dose and in the mean carotid dose and a preservation of our PTV coverage. So just in conclusion, I think IMRT for early stage glottic cancer unquestionably offers better carotid sparing. From our own institutional experience, there's no concomitant increase in local failure. At our institution currently, IMRT, we do IMRT for almost all T1 and T2 glottic cancers. Future direction, some groups have reported on unilateral vocal cord irradiation at the Princess Margaret and Erasmus. And then the question of whether IMRT could afford greater arytenoid sparing and better voice quality is also an open one. Thank you very much.
So, any comments or questions? I like to explain something. I don't know whether everybody knows what is a PTV. It's the planning target volume. So this is the main definition for the radiation oncologist. And I think most of the people here in the room are ENT oncologists. I have a question to Sean McBride. One question. Sure. Do you think there is a role of radiochemotherapy in early laryngeal cancer?
So that's a very good question. I think there was a recent report out of Japan that suggested that radiochemotherapy afforded an increased local control benefit in T2 and 0 glottic cancer. So I think that, I think settling for a 79% local control rate, I think in most other tumor subsites, we would view that as something that could be improved upon. And I certainly think that the addition of chemotherapy might be an avenue to improve on that. I think the other thing is that IMRT might afford us the ability for some amount of dose escalation to the gross tumor that could also maybe obviate the need for chemotherapy, but the question of voice quality at the end of all that would be an important one.
May I have just, excuse me, another question? Regarding obviously, it's very nice results regarding the side effects, control on carotid arteries. Is there some experience regarding sparing of the contralateral vocal cords with MRI?
With MRI?
Obviously with T1A cases.
There have been some reports, and I think the Princess Margaret Hospital is sparing the contralateral vocal cord, and they're using daily setup imaging that includes cone beam, these low-dose CT scans with every fraction of radiation delivered to try to accomplish that. And they've reported excellent local control when they've used the cone beam CT scans to set up based on laryngeal soft tissue anatomy. So the answer is yes. There have been some reports of that. We have not done that at our institution, but some other institutions have started that process.
Susan, do you have some?
Yes, I think it's very nice, and it's quite easy to do this because all the modern Nilo accelerators are providing image-guided radiotherapy. This is the use of these low-dose CAT scans in front of every fraction daily. So we are doing this on prostate cancer. It's also another organ, but a small volume for the radiation oncologist. And I think we will do this also for a vocal cord or glottic cancer.
Yeah, I think a lot of institutions will be moving towards that in the next few years.